Hello, I'm Dr. Sunil Verma, Reader, Department of Periodontology, BBD College of Dental Sciences, BBD University, Lucknow. Today, I'll cover the topic of subject periodontology, and the topic is abscesses of the periodontium. Abscesses of the periodontium is a very interesting topic because in society you see that बहुत लोग कहते हैं कि मसूड़ों में पस पड़ गया है, लगता है इनको डायरिया हो गया है, अब तो ये ठीक नहीं होगा, एक बार अगर पस पड़ जाता है तो बहुत दिक्कत हो जाती है। सो इन भ्रांतियों को दूर करने के लिए समाज में ऐसी मिसलीडिंग इन्फॉर्मेशन को दूर करने के लिए I'll cover this topic that is called as abscess of the periodontium. Abscesses frequently means pus. Okay. So there are three types of abscesses. One is gingival abscess, second one is periodontal abscess, and third one is pericoronal abscess. I'll first talk about gingival abscess. This is a abscess localized in the gingiva, involves the marginal gingiva and not involving the supporting tissue. Means only gingival component of periodontium is involved, not other components are involved in this abscess. Etiological factors are basically the first and foremost etiological factor is microbial plaque infection, or it may be due to trauma, or it may be due to foreign body impaction. Clinical features are, clinically you'll find red, smooth, sometimes painful, fluctuant swelling. Second one is periodontal abscess. This is localized purulent inflammation in periodontal tissue, also called as lateral abscess or parietal abscess. In this, other components may be involved. Means in periodontal abscess, other components like alveolar bone or periodontal ligament space may also be involved. A microbiology of these abscesses, it may be gingival or periodontal. The prevalent microorganisms which are responsible are P. intermedia, F. nucleatum, and P. gingivalis. All right, and other microorganisms are Lacuride or sulfocythus, P. micros, P. melanogenicus, and Campylobacter rectus. These are the microorganisms which are responsible for this disease. Again, I'm repeating this. The prevalent microorganisms which are responsible for the disease initiation are Proboscis intermedia, Fusobacterium nucleatum, Porphyromonas gingivalis. Other microorganisms are Lacuride forsythus, P. micros, P. melanogenicus, and Campylobacter rectus. Now, what are the microscopic features which are the characteristic features of these abscesses? They are the, firstly you'll see it is a localized accumulation of viable and non-viable polymorphonuclear leukocytes. Basically, in challenge, the microbial challenge stimulate polymorphonuclear leukocytes to liberate enzymes that digest the cells and other tissue structures, forming liquid product called as pus. All right. Therefore, if you see any abscess, the center of the abscess contains pus, surrounding structures contains acute inflammatory cells, and overlying epithelium having intracellular and extracellular edema plus white blood, other white blood cells. Now, how you clinically determine clinically how this operation extension. Placing a ball of index finger along with the lateral aspect of the marginal gingiva, applying pressure in a rolling motion towards crown, means इंडेक्स फिंगर की बॉल इंडेक्स फिंगर की टिप को प्रेस करेंगे. प्रेस करने के बाद अगर आप कोरोनरी उसको अपाइटर को कोरोनरी मूव कराएंगे तो थोड़ा सा रोलिंग मोशन आएगा पेरियोडोंटल एब्सेस. दिस इज द कैरेक्टरिस्टिक फाइंडिंग ऑफ पेरियोडोंटल एब्सेस. Now, periodontal abscess are two types. One is acute periodontal abscess, another is chronic periodontal abscess. Acute periodontal abscess appear as an ovoid elevation of gingiva along with lateral aspect of the root. In this, gingiva is edematous and red, smooth and shining surface, and dome-like and relatively firm or pointed or soft. It depends on the category of inflammation or stage of inflammation. Important aspect that the patient feel that the symptoms are throbbing, radiating pain. All right. There is severe tenderness of the gingiva to the palpation. There is sensitivity to tooth on palpation. There will be tooth mobility, especially lateral aspect, lateral mobility. And there is lymphadenopathy, especially sublingual or submandibular lymph node may be enlarged. And if systemic fat, if it spreads inside the body, there may be systemic features may also appear like fever, leukocytosis, and malaise. Second classification of periodontal abscess is called as chronic periodontal abscess. It usually presents a sinus that opens into the gingival mucosa somewhere along the length of the root. All right. The orifice of the sinus may present a difficult to detect pinpoint opening, which is when probed reveals a sinus tract deep in the periodontium. Basically, chronic periodontal abscess is converted when acute periodontal abscess is not treated, and when their abscess is automatically removed, it may go to slow healing and occlusion period, and it may cause chronic periodontal abscess. And basically, what happened? If you probe if you probe direct pinpoint opening, then you'll find a sinus tract deep into the periodontium. The sinus may be covered by small pink bead-like mass of granulation tissue. The symptoms of chronic periodontal abscess are usually asymptomatic because of always if there is increase in pus formation, there is drainage, so there will be no pressure, and episodes of dull, gnawing pain or slight elevation of the tooth due to inflammation or desire to bite down or grind the tooth because of elevation, and often undergo acute exacerbation with associated symptoms. Whenever there will be entrapment of pus inside the chronic periodontal abscess, there will be pain, and when this pressure exceeds threshold, the drainage will automatically occur and there will be no pain. So this is basically a disease where there is a period of quiescence or exacerbation. When there is pus entrapment, there will be pain. If there is drainage of pus, automatically there will be no pain. Now, one aspect is very important, that there is no there is not necessarily the pocket abscess is basically drained in the same surface where it is originated. It may be that it may be located on the same surface of the root as the pocket from the which is formed, because drainage is likely to be impaired when pocket follows a tortuous course. Means, suppose the abscess is in lingual aspect of the root, and it follows tortuous route along the least resistance, and it drains on the buccal surface or proximal surface. Well, you may confuse that the problem is on proximal surface. So always remember, it may be misleading that origin may be on different surface. In children, sinus orifice on lateral surface is usually a result of periapical infection of the deciduous tooth, because deciduous tooth basically located on the coronal aspect of the permanent tooth. Sometimes there will be misleading information that there is lateral periodontal abscess, but actually this is a periapical infection of deciduous tooth. In permanent dentition, such orifice may be caused by both periodontal abscess or periapical involvement. Diagnosis. The diagnosis is basically based on three aspects: history taking, clinical findings, and radiographic findings. पेशेंट से आप हमेशा पूछेंगे कि कुछ खाते समय कुछ फंसा तो नहीं था, आपको ऐसा लग तो नहीं रहा कि कुछ फंस गया हो वहाँ पे, okay? And the clinical findings will see there is frank formation, pus formation or not. Radiographically, there is discrete area of radiolucency along the lateral aspect of the root, and however, radiographic features are not always typical because of lateral aspect of radiolucency. Root may be superimposed over the radiolucent area. Now, how do you differentiate between periodontal abscess and gingival abscess? Gingival abscess is confined to the marginal gingiva, whereas periodontal abscess involves the supporting periodontal structures. First difference. Second one is gingival abscess occurs in a previously disease-free areas. It is usually an acute inflammatory. This acute inflammatory response to forcing foreign material into the gingiva. Means कोई भी कड़ी चीज, कोई भी ऐसी चीज जो दांतों को मसोड़ों के बीच में जाके धंस जाए, may cause gingival abscess, whereas periapical abscess usually occurs in a course of chronic periodontitis where there is deep pocket. Now, again, there is confusion between periapical and periodontal abscess. You should know how you differentially diagnose between the periapical abscess and periodontal abscess. The pulp in periapical abscess, pulp test may be non-vital. Means once there is periapical abscess, there may be initially there was caries. After that, there was reversible pulpitis, then irreversible pulpitis, then acute apical periodontitis, then apical periapical abscess. That there are 4 or 5 consequences where we'll find the death of the pulp. And in periapical abscess, usually it is non-vital. And in periodontal abscess, because infection goes through pocket area, if it doesn't go to apical area, then pulp test may be vital. Apical refraction in the radiograph will find in periapical abscess, and in periodontal abscess, the radiolucent area is along with lateral aspect of the root. In periapical abscess, there is sinus located more apically, especially at the apical aspect of the root tip. And in periodontal abscess, sinus is usually located on the lateral aspect of the root, before apex. Acute apical abscess is more painful because of entrapment of pus. If there is no sinus formation, there will be pain. There will be severe pain with pressure. And in periodontal abscess, comparatively this is less painful because of drainage constantly occurs through pocket area. In periapical abscess, there's formation of fistula is more common. Due to there is there is lining of the sinus, and there is a formation of epithelial lining in the sinus area, and constant drainage. Sure, this is a defensive phenomenon, and constant drainage should be established in the periapical area. And fistula is less common in periodontal abscess due to constant drainage through pocket area. Associated with deep restorations, again, I have already told you that this is a consequence of caries and reversible irreversible acute periodontitis. All right. But in periodontal abscess, this is associated with a pre-existing periodontal pocket, caries, or endoperioral lesions. Come to the treatment protocols or treatment options for periodontal abscess. First, you should drain the abscess through pocket retraction. The first and foremost aspect is drain the abscess. Second thing, if there is any obstruction due to calculus or any foreign body, then you should do scaling and root training to establish that root surface should be smooth, there should be no and then plaque and calculus present in the pocket area. If patient is not getting benefited from this above two mentioned treatment protocols or treatment procedures, then we will perform periodontal surgery. And along with these, the adjunct use of systemic antimicrobial is also recommended. And if its patient is not getting benefited by all these other four procedures or protocols, then tooth extraction is the last option. Now, how will you treat periodontal abscess? There are two ways by which you can drain the abscess. One is drain through the pocket, and other is drain through the external incision. Firstly, because this is a painful procedure, so we'll anesthetize the area, and the flat instrument or probe is introduced in the pocket and go apically, and curette is inserted for further drainage and widening of drainage area, and curettage should be done. All right, this is a procedure in which you see the drainage through pocket area. I'll insert periodontal probe inside the pocket area and drain the periodontal abscess through probe. Now, second treatment procedure is drainage through the external incision. Firstly, we'll isolate and dry, and after that we will anesthetize the area, and we will give vertical incision through the most fluctuant part of the swelling. Important aspect, most fluctuant part of the swelling, extending just apical to the abscess with blade number 50. Then we will curette by means of curette or periostal elevator. We will elevate and create a drainage. We will elevate elevate the flap and slightly elevate the flap and create drainage. And external aspect is gently pushed for removal of residual pus, and area is dried and painted with any antiseptic like Providone iodine. Now, if there is systemic complication like fever, malaise, or lymphadenopathy, then there are indications of antimicrobial therapy in patients with acute abscess, like cellulitis, especially facial inflammation of facial spaces. If there is cellulitis, this is a complication of abscesses. If there is cellulitis or deep inaccessible pocket, or there is fever, or there is regional and lymphadenopathy, or the patient is immunocompromised, we will go for antimicrobial therapy. And the antimicrobial options for periodontal abscess are: first, antimicrobial choice is antimicrobial agent of choice is amoxicillin 500 milligram twice a day. In acute cases, we can give 1 to 2 gram, even nowadays 2 gram of loading dose can be given, and then 500 milligram thrice a day for 3 days. All right, after 3 days, we will re-evaluate to determine need for continued or adjusted antimicrobial therapy. If patient is allergic to penicillin, we can give clindamycin. All right, the dose is of clindamycin is 600 milligram, then 300 milligram, 4 times a day for 3 days. Azithromycin can be also given 1 gram of loading dose, then 500 milligram once a day for 3 days. Now, instructions for the patient after incision and drainage. The first instruction is frequent rinsing with solution of 1 teaspoonful salt with a glass of warm water. Warm saline gargle should be given. Prescribe antimicrobials, already described, and as well as analgesics can be also given to reduce temperature. And patient should go for bed rest, avoid exertion, and he or she should take copious fluid intake, and written on follow-up evaluation on next day. Apart from gingival abscess, periodontal abscess, third abscess is called as pericoronal abscess, and pericoronal abscess is basically the inflammation of the soft tissue upper column, which covers a partially erupted tooth, the most commonly around mandibular third molars, caused by retention of microbial plaque, food infection, or trauma. Treatment of pericoronal abscess: just like acute phase of periodontal abscess. And if there is resolution of chronic conditions, then we'll surgically excise overlying tissue and removal of offending tooth. So this is all about management of 3 abscesses. One is gingival abscess, second one is periodontal abscess, and third one is pericoronal abscess. Thank you.